Hey there, everybody. I'm Alan Doderlein, the president of the Depression and Bipolar Support Alliance, or DBSA. And it's my great pleasure on behalf of the DBSA family of board, staff, volunteers, and chapter participants across the country to welcome you to Better Is Not Well 2014, Consumer Clinician Collaboration for Raising Treatment Expectations. We have been working towards this day for quite a while, and it's very important that we launch this conversation. So I thank all of you here for being part of what we hope will be the beginning of a shift in our community, from a focus on surviving symptoms to a focus on creating thriving lives. That's what we're about at DBSA, and that's what the Better Is Not Well panel today is all about. I thank you for joining us for what I know will be a lively discussion and one that I hope you all feel compelled to participate in. And I am very thankful that I don't have to talk to you all by myself. That would be very scary, but I feel great because I'm surrounded by wonderful collaborators that I'm so glad to have with us on the panel today. We have with us Dr. William Gilmer from Northwestern University, and he is also a member of the DBSA Board of Directors and a member of the DBSA Scientific Advisory Board. Joining us to his right is Rebecca Folk, who is the founder and president of DBSA Central Illinois. We have Dr. Judith Cook on the far right from University of Illinois, Chicago, and she is a former member of the DBSA board and longtime friend. And then just to my right, we have Robert Haggard, who is a peer recovery crisis counselor at Turning Point in Skokie, Illinois. So from the perspectives of a psychiatrist, of a psychologist researcher, and of people with the lived experience of a mood disorder diagnosis who work in peer support groups and in peer support specialist roles, we will be talking about how we as a community can begin to raise our expectations from better to truly well. So I'll begin by going into what we'll cover today, give you the lay of the land a bit, and go over some housekeeping details. So right now we are in the welcome and overview, so I hope you're excited about that. We'll talk a bit about why this is so important to us at DBSA, why we decided to take this on, and why we think that this is a central and essential focus for our community. And then we'll have the panel discussion where we will look at the issue of how we can do just that, raise expectations from the points of view of a clinical professional, of a person in the peer support context, and from a position of research. And then finally, we'll get to, I think, the most important part of today, and that's when we hear from you. And that's to hear from those of you who are here with us in Chicago, Illinois, at the Chicago School of Professional Psychology. Thank you for giving of a sunny afternoon in Chicago. Those are rare, so you really want to be here, and we appreciate that. We're also so glad to have folks from all over the country participating online and watching this live. And then we have some viewing parties going on. I want to tell everybody about how to submit a question. So if you're in the room, it's pretty simple. We have on all of your chairs cards where you can write your question down. You do not need to list your name. And you can pass them to any member of our team, and the team is walking around. They have name tags on. They'll take your question and bring them up to us on the panel. If you are there watching at home or from your office, you can type your question into the chat box at dbsalliance.org/BINW. That's B better I is, and not W well. And we'll get all of those together and aggregated with those from in the room, and we'll begin that panel after we've had presentations from each of our panelists. So welcome, as I said, to the folks in Chicago and online. And then our chapters, of which we have 300 across the country, are doing some viewing parties. And I'm really glad to know that there are folks watching us from here in the city. Actually, a group decided to, right here in Chicago, be watching. And hello to the DBSA Chicago Loop chapter. Our friends with DBSA Louisville in Louisville, Kentucky, hello to you. We've got DBSA New York appropriately in Wellsville, New York, so they should be able to tell us a thing or two about what we're talking about. Hello, Wellsville. And DBSA Overland Park in Leawood, Kansas. So again, thank you to those folks who are watching us all over the country. And with that, I'd like to give a bit of context about DBSA as an organization and about why we decided to take this on. So DBSA is about to celebrate its 30th year in existence, and we have been, for that entire time, been by and for people who live with depression and bipolar disorder. And what I mean by that is we are an organization made up of people who have a diagnosis. That's at the board level, at the paid professional staff level where I sit, at the volunteer level, and at the chapter level. We are over half made up of people who know what it is to have depression, to have bipolar disorder, and that experience informs absolutely everything we do, whether it's our educational materials, whether it's our work to train, or whether it's presentations like this. It's all informed by what it is to have these conditions, and I think that's a really important point. And we've heard a lot in our community about what is our quote-unquote moonshot. I'm quoting our dear friend and advocate, Congressman Patrick Kennedy, who referred to that. And for him, it was the idea of the map of the brain. How can we understand better what the brain is all about? There are others in the community who talk about a cure. That can be a charged word for many people. Some would say they would not want to see a cure. Others very much would like to see a cure. And whether or not we get into that, that is a perspective in the community. For us at DBSA, we are a place for everyone, wherever they are in their journey to wellness, to find a safe home. And we thought, well, what is missing from this conversation? And what we saw was that there was no mention, no discussion of thriving. We were talking so much about surviving symptoms. We were talking about danger and drain from those of us who have mental health conditions. And our commitment is to showing that we're not surviving symptoms, we're creating thriving lives. That we are not danger nor drain, but collaboration and contribution. And with that, we launched for 2014 our Year of Thriving. A year-long focus, and I promise you it will go beyond 1 year, but this is how we've themed 2014. It's a year-long challenge to ourselves and our community to raise our expectations from better to well, as we'll discuss today, to demand a new focus on treatment options that have the endpoint of wellness and research that supports it, and we have a call to action for all of our community to join and to help to make this a reality, because it's not something that is done solely by doctors and other clinical professionals. It's not done solely by professionals and researchers. I think the bulk of the work, the paradigm shift, needs to happen from within, and that's something that I hope we can take away today. So why thriving is important? It makes sense. Certainly we feel that everyone can and deserves to have a great life. That's the right thing to do. It's empowering, it's person-centered, and who would argue that everyone deserves a meaningful life? It makes sense. What I didn't realize when we embarked upon this journey is that there are very important clinical imperatives to striving to get all the way to wellness. I did not know that. And when I learned about it, I was really quite shocked. And I'd like to share a bit about that because I think it puts into context why this is more than a catchy slogan, a nice thing that rhymes, surviving to thriving, better is not well. It's much more than that. It is absolutely important. In fact, the cost of settling for surviving rather than thriving is a matter of life and death. So in terms of the research that exists about our courses with depression or bipolar disorder, when we who have mood disorder diagnoses are better and not all the way to well, we are at a significantly greater risk of relapse. This resonated with me personally, and as an organization of people who have depression or bipolar disorder diagnoses, I think that that's important. The idea that, well, I'm doing great. I'm working. I have great relationships. Life is really good. I do still tend to sleep erratically, not much sleep at all during the week, and sleep almost the entire weekend, but things are great. Or times when I'm doing great, I'm in good spirits, I'm connecting with my community and really happy about a lot of things, and I'm about 60 pounds overweight, and I'm anxious nearly all the time. That's something that I see folks in the room nodding about, and something that our constituents across the country said time and time again. That resonated with them. The idea that we were taking better as the end point of our journey and not realizing that there was so much further to go. Well, the fact is that when we still have leftover symptoms of depression or bipolar disorder, or when we're not all the way to that destination of wellness, whatever we define that as, we run the risk not only of relapse, but also more severe and longer course of illness. So there's a very significant reason that we begin this shift in how we think about treating depression and bipolar disorder. Also, when we are better and not truly well, we're more likely to experience significant functional impairment. So depression, I'll take depression discreetly for just a moment and say that depression has a suite of symptoms, sometimes called a constellation of symptoms. And these run from those that we might typically associate with depression: sadness, loss of interest in certain once enjoyable things, low mood persistent for a long period of time. But there are also issues like cognitive impairment, inability to think as clearly as you once felt that you did, impairment to executive function, loss of sleep, irritability, agitation, things that can really get in the way of your ability to work, to have normal relationships. And depression is the leading cause of disability between the ages of 18 and 49 in the United States, and estimated to be the leading cause of disability worldwide by 2030, according to the World Health Organization. So the fact is, when we have leftover symptoms of depression, symptoms that some may not even associate with depression, we run the risk of not being able to work and not being able to lead the lives that we would want to lead. When we are better and not truly well, we're more likely to have life-threatening co-occurring conditions. And there is a very real risk of life and death stakes with depression and bipolar disorder, but the fact is what we die of is not wasting away from depression or often or always the impulsive acts that we might associate with mania or hypomania. In fact, we die earlier, up to 25 years earlier than folks without depression or bipolar disorder because of those co-occurring conditions: heart disease, diabetes, etc. And so it's very important that we look at whether or not we have persistent mood-related symptoms as they signal this vulnerability to the other co-occurring conditions. And finally, and very importantly, when we have leftover symptoms, when we're better, but not all the way to well, we're at a much greater risk to die by suicide. And that is something that we've been talking and thinking about a lot lately, and I think that it's important to realize that that can be helped, it can be forestalled if we focus not just on being better, but on being well. And that's why we're here today. So there are a lot of reasons why we might have, in some respects, lowered expectations, and I want to talk before we move things over to our panel about why those expectations might be low. And I'd like to talk about it from a couple of different vantage points. So first of all, I'd like to talk about the clinical context, when we who have mood disorders are going into treatment, what we experience. And we'll hear more from clinical professionals themselves about what this is, but generally speaking, there are, as we all know, increasingly high demands and limited amounts of time for our interactions with clinicians. So to actually persist and have the time you need for assessment, for follow-through, and for redirection if you aren't getting all the way to wellness is incredibly limited. It is a very hard thing to actually get that conversation on the table with your doctor and for your doctor to entertain it. And then I'd like to quote our wonderful Scientific Advisory Board Chair, Greg Simon, who said, "We may have confused what we have with what we want." The idea that there are treatments, some of which work very well for some of us, some of which unfortunately do not work for some people at all, and a big middle in which there are treatments that are only moderately effective for most people. And the fact is, we need to strive for treatments that actually have as their endpoints wellness or complete remission, if you think of it that way, rather than stepwise or modest improvement. Then we have the idea of the medical model or surgical model, I think is even more evocative. And whether or not we get into the sometimes polarizing debate about medical versus recovery model, that's not what I mean. I mean rather the idea that we've looked at the issues of mood symptoms as their own thing. We focused only on them as if they don't happen inside a body, inside a life, and that isolated focus really tends to focus on eliminating or managing symptoms only, and not the context in which they operate. And so we have a big lift, we have a big challenge in terms of shifting the paradigm, because really, given the time constraints, given the endpoints of treatment being what they are, and given this long history of focusing solely on the mood-related issues, there's a big amount of change that needs to happen. And so I think that that's something to consider, the clinical reality we face when we go into our clinician's office. And then the fact that we present very often when we're very ill or in crisis. That's something we may not be acculturated to go to the doctor until it gets that bad. And then given the expense of seeing clinicians, the fact that there are not very many clinicians in a lot of communities, or the clinicians that are available may not be accessible to you, you really don't wind up at the doctor until you're very sick. That means that we are focusing on stabilization, on getting better. And we're not then fine-tuning and evolving and continuing on the journey. That's part of it as well. So then in terms of research, the endpoints of research, as I understand it from colleagues like Dr. Simon, whom I mentioned, and longtime member of our Scientific Advisory Board and friend Joseph Calabrese, the endpoints of research have traditionally skewed low. The idea being that the number needed to treat, or NND, has been low given the nature of research, and the proof of efficacy is a stepwise improvement, and the endpoint of wellness has not been targeted. So the culture of research is already inherently at a bar that is lower than wellness. There's been much more of focus on symptom reduction rather than wellness. Function, which I think there's a lot of research that certainly panelists like, or researchers like Judith Cook, one of our panelists, have brought into the fold, and that idea that it's not just the symptoms, but also your ability to live your life and do things like work and have relationships. And then how depression or bipolar disorder affects your other aspects of health. That this is not just a condition of the brain, it's something that affects your body in various key ways. And so bringing all of that together, doing whole health and integrated research is very much, I think, what we're seeing now, but it is sadly new. And so that's something that's going to take some time. Then again, if we think of where research happens, if we think of the major research institutions, major hospitals and clinics that have the top flight research environments, those are places where you're going to see a preponderance of people who are acutely ill. And the fact is, people who are not as acutely suffering but are still dealing with depression or bipolar disorder are not participating in research. So the idea of how do we go from moderately functional to fully functional, how do we go from improvement of symptoms to presence of wellness, is not in the context of the people who are participating in research. And then, and this can be hard, I think, to think about what in ourselves, in those of us who have a mental health condition, depression or bipolar disorder, what might be holding us back or keeping us from thinking of wellness as an option. And the first thing I'll say very plainly is it's hard to get better in the first place. I don't know about anybody else, but the fact of getting better at all seems impossible when I'm at the affect of depression. And so I sometimes just think, oh my gosh, I've won because I can get out of bed. I've won because I want to talk to anyone in the world. And then to go beyond that doesn't even occur to me because I feel like I've already crossed the finish line. Maybe we don't want to set ourselves up for disappointment. When we asked this very question of various participants, we said, what is one of the things that may hold us back? And the idea being, well, if I keep my expectations low, I'll never be disappointed. And I think that's a cultural and personal thing we have to contend with, not wanting to rock the boat. When we do have complex and entwined systems and methodologies of care, when we're combining various medications, perhaps, we are involving talk therapy, we're dealing with various lifestyle choices. There are so many things that go into that, as Dr. Ellen Frank calls it, the cookbook. And if we get something that works a bit, it's really, really hard to think about changing it, because what if we lose some of the gains we've made thus far? The stakes feel very high, and so we might, for that reason, not persist from getting better to getting well. And then there's the idea of the new normal, the idea that maybe we've gotten so used to things as they are, with a little bit of depression, with a little bit of mood dysregulation, that it's not that we consciously are having lowered expectations, it's that we don't see anything else. And there are some people who would say that they've never had a moment where they've not experienced some depression or some mood dysregulation. And so the idea that there would be something that's better is not even in their world at all. We are entering into systems that are focused on that medical or surgical model that looks only at symptom reduction, or predominantly at symptom reduction, as we work to change it, and that can hold us back. And there's also the idea of defining wellness. There are some great definitions of wellness or recovery that are out there, but wellness is also something that is highly personal. We at DBSA would say that your definition of wellness is what you need to focus on, but until we maybe have ways of quantifying it, measuring it, it's something that may be off the table for us as individuals. So I'd like to, before I go into our panelists, make one distinction for you, and something that even we who work at DBSA or who work in the peer community have trouble discerning or understanding. So I just want to lay a little more groundwork and talk about the distinction between peer support and peer support services, because we're going to hear from a panelist, Rebecca Folk, who is involved in peer support. We'll also hear from a panelist, Robert Haggard, who I believe also is familiar with peer support, but is working, and we'll talk about today, his work as a peer specialist. So we're very committed to the peer movement. We have 53,000 people in a given year who are meeting in free in-person peer support groups across the country. We're also part of training peer specialists, including a high number of veterans. We were very proud to be involved with training in 2013 and 2014. Peer support is people with similar mental health experiences giving each other hope, guidance, and understanding that lead to wellness and recovery. It is a mutual support environment. There is not a hierarchy. There is not a provider and a person receiving services. It's truly mutual, and it can happen anywhere to a certain extent. It's something that can happen in the DBSA context, in community centers, in clinics, in church basements. You can have a peer support group, and that's peer support. Then peer support services are a bit more formal. They do rely on the spirit and many of the ways in which peer support itself is efficacious, but it is actually providing as a service that idea of support. So it's in a clinical or other treatment context where a person has been trained to use her or his experience in attaining wellness or recovery, and then provides a listening ear and a way of holding on to goals, to hope for someone who is in that treatment environment in which the peer support specialist works. So I wanted to make that distinction because we'll be talking about both, and they both start with peer support, so it's confusing. Wanted to go into that just briefly. And we do have support groups, and whenever I give a talk, I always mention that you can find a support group in your area by visiting dbsalliance.org/find support. And you can, on this map, you can enter your zip code and see what support groups may be within a given radius of your area. And that's something I hope that you'll learn about and take advantage of, and perhaps you already do. So with that, I will hydrate briefly. And now I would like to introduce our panelists and tell you a little bit more about them. I'm going to go ahead and introduce everybody all at once. So I guess I do want to talk some more. But then I will give it over entirely, and we'll hear from our panelists and go into the various contexts that I outlined previously. So first off, it's really great to have our friend, board member, and scientific advisory board member, William Gilmer, with us. He is an associate clinical professor in the Department of Psychiatry and Behavioral Sciences at Northwestern University Feinberg School of Medicine here in Chicago. Dr. Gilmer has specialized in the treatment of depression and bipolar disorders for 22 years and has conducted numerous research studies in the development of new treatment approaches for depression. He was the director of the Northwestern University Regional Center of the NIMH Depression Treatment Network, which was a federally funded research consortium that conducted the STAR-D study, which was a landmark multi-center study designed to evaluate treatment options for people living with major depressive disorder in a systematic way. It was a groundbreaking, first of its kind study, and Dr. Gilmer was a key participant and driver from Northwestern. Dr. Gilmer was medical director for the Asher Depression Center at Northwestern from 1997 to 2009, and his clinical and research interests include the investigation of novel depression treatments, including transcranial magnetic stimulation, subtypes of chronic and recurrent depressions, identification of bipolar spectrum disorders, and factors that influence the course of depression or bipolar disorder. He is the co-author or author of over 60 papers and published abstracts pertaining to mood disorders and numerous book chapters. He is a distinguished fellow of the American Psychiatric Association and is currently, as I said, on the board of directors and the scientific advisory board of DBSA, and we're very glad to have Dr. William Gilmer with us. Rebecca Folk, to Dr. Gilmer's right and my left, is a contractual data analyst and accounting professional for the state of Illinois, and she's a freelance web designer and photo editor as well. She founded DBSA Central Illinois in July 2009 and is currently its board president. And in her work with DBSA Central Illinois, she facilitates support groups, conducts relapse prevention groups for a partial hospitalization program, and educates local law enforcement professionals in crisis intervention team or CIT training. She presented the breakout session Joining Forces, Partnering with Professionals at the 2013 DBSA Chapter Leadership Forum and Conference in Miami. She is majoring in biology at the University of Illinois Springfield in preparation for a clinical career in mental health, which I think is awesome. That's Rebecca, and very glad to have her as well. To my right, all the way at the end, is Dr. Judith Cook. She's an internationally recognized authority on mental health services research, and specifically the study of clinical and rehabilitation outcomes of children and adults receiving community-based care. She directs a federally funded research center along with numerous grants focused on intervention science and psychiatric epidemiology. She designs and implements innovative programs to enhance health and behavioral health of vulnerable populations and works with federal, state, and local authorities on behavioral health service system redesign and alternative financing strategies. So Dr. Cook is really dealing with how we change the whole system of care, which is very inspiring. Her recent work focuses on randomized controlled trials of evidence-based practice treatments for serious mental illness and outcomes for individuals with co-occurring mental health conditions and chronic physical medical conditions. She consults with federal agencies including the National Institutes of Health, Social Security Administration, Department of Labor, Government Accountability Office, Substance Abuse and Mental Health Services Administration, and the Veterans Administration. Dr. Cook is currently the principal investigator for the first national study of the prevalence of psychiatric and substance use disorders among women living with HIV and AIDS. Dr. Cook was a member of the NIMH study section on mental health services in specialty settings from 2006 to 2009. I'm very glad to have Dr. Cook with us, a former member of the DBSA board, and I don't know how she had time for that, and Robert Haggard to my immediate right. Robert is a peer recovery crisis counselor at Turning Point Behavioral Health Center here in Skokie, Illinois. Prior to moving to Chicago in 2008, Robert graduated with his associate's and bachelor's degrees in the arts from Washburn University in Topeka, Kansas. He has served on the NAMI Topeka Board of Directors, presented for a number of police CIT trainings, and served as a member of the Topeka Mayor's Council on Youth Suicide Prevention. Robert hopes to educate people, advocate for those directly affected, and works to eradicate mental illness and its stigma wherever possible. Robert is hopeful and actively helps those in acute crisis work towards a more wholly recovered modality of living. Robert helped open the living room at Turning Point Behavioral Health Care Center 3 years ago, joining their team part-time. Page turn. Joining their part-time clinical staff as a peer recovery crisis counselor, and he's testing for the Certified Recovery Support Specialist state certification this year. He is a qualified mental health professional here in Illinois. So quite an impressive panel. Makes me feel like I got to get my hustle on and get some letters and such behind my name, so I'll work on that after this presentation. So we'd like to start by talking about the treatment environment, the clinical context. So when we go to the doctor's office, in this case, we have Dr. Gilmer, who is a psychiatrist, and in addition to his work as a teacher and researcher, he has, for that entire 22-year period I mentioned, also actively seen patients. And Dr. Gilmer, in terms of these lowered expectations, how have you seen those in your practice, in your research, and in addition to that, what do you think some of the reasons for that are, and how can we work to make it better?
Wow.
In 5 minutes,
in 5
Bill.
minutes, or less. First of all, Alan, you have more than enough hustle, so you need not worry about catching up with anything. I want to commend DBSA and all the staff for this initiative, for this conference, as well as all the other initiatives that you've undertaken related to increasing awareness about the importance of wellness. And wellness is not better. Wellness is more than remission even. It's truly being well, both in a symptomatic as well as a functional sense. And you mentioned STAR-D, and I appreciate that. So I think that's where I really came to appreciate the importance of targeting complete wellness or remission. From that study, which Alan mentioned, was a very large naturalistic study. It was probably the largest, as much real world as a prospective outcome study could be, that looked at the course of mood disorders and their treatment over time. And one of the things that we found in that study was that the presence of even a few symptoms amongst people who got well, who met criteria for remission that the FDA would have considered to meet remission, that even the presence of a few symptoms put those individuals at greater risk of relapse in the coming year than those people who got completely well. And hence, the presence of even a few symptoms, minimal, what anyone would consider subsyndromal, can have significant clinical outcomes and importance. And so that finding has been replicated and was demonstrated in smaller studies certainly before that. But I think it really brought a lot more importance to this whole idea. And you know, when I was trying to think of a term that would maybe encapsulate all the factors that are involved in terms of why we settle for better versus well. And the term inadequacy kept coming to mind. And inadequate in terms of expectations, inadequate recognition of residual symptoms, inadequate assessment of residual symptoms, and quite frankly, inadequate time to evaluate how a person is actually functioning. And that means a lot more than just their symptoms. So I'll quickly try to go through each of those areas. In terms of expectations, I think we'll probably talk a fair amount about that. All of us will talk about that, and you've addressed some of those reasons. But I think one of the things as a clinician that happens is that seldom, I think, do we ask, what are our expected or our target outcomes before we start treatment? What are we trying to accomplish? How will we know that we've accomplished it? And that's a discussion that needs to happen between the clinician and patient. It's a partnership. Treatment is a partnership. And that kind of discussion, what are we going for? How will we know when we've reached there? Has to occur right up front. The other thing, I think sometimes there's a little bit of a mutual collusion in that the patient may come in, the individual living with the depression may come in and say, gee, doc, I'm feeling better. And doc says, well, that's great, terrific. We each pat ourselves on the back and say, you know, well, we'll see you again in 3 months. And that's where the discussion ends. And I think there's that mutual collusion that just naturally happens that unfortunately perpetuates a lot of under-recognition of symptomatology. And so that's the next area I want to talk about in terms of recognition. And that is I think the really sad lack of measurement-based care in clinical settings. As a researcher, and certainly Dr. Cook can address to this for sure, you know, we use a lot of measurements, a lot of outcomes to determine how we are doing. And I think a lot of clinicians find rating scales and checklists and things, they find them off-putting and find them devaluing or kind of trivial in some way. And I think if they're incorporated into a truly comprehensive, holistic evaluation, they can be incredibly important because they make sure that everyone is being thorough. They make sure the clinician's being thorough in evaluating all the symptomatology. It's a way to remind us, where were we 12 weeks ago? Where were we 12 months ago? Where were we 18 months ago? Are we making progress or not? And it's a way to pick up very, very subtle subsyndromal symptoms that otherwise would be missed if you're just saying, hey, how you doing? I'm great. You know, I'm going out with my friends. I'm doing good. I'm sleeping not too bad. If you keep it at that, you never, ever will recognize those residual symptoms. So it's very important. And there's good, actually, measurement outcomes, not simply for symptoms that we all know, but for outcomes, functional outcomes. And I think that whether it be through a verbal discussion or through an actual written form of some sort that methodically evaluates outcomes, I think that we really need to push for outcomes measurement-based care more in clinical practice. Another thing that doesn't happen often enough is identification of individualized flags or symptoms. I mean, Alan alluded to the, the standard checklist of symptoms that you would find in the DSM or anywhere like that. But these are the subtle things, the things that aren't going to be on a checklist, but that might be unique for that particular individual, or that may they may signal that they're having recurrence. For example, perhaps it's for some people it might be that they recognize they're drinking a little bit more coffee in the morning, or maybe they're coming home from work and having an extra glass of wine 4 days a week versus having a glass of wine once a week. Maybe it's they're smoking a little bit more. Perhaps they're just feeling a little bit more kind of old and haggard, and they look in the mirror and kind of more likely to say some kind of subtle self-critical things, or they're more annoyed by the kids, or they're more annoyed by their colleagues, or more simple things just seem a little bit more of a struggle, or you find yourself saying, man, I'm tired of this job, or just kind of general dissatisfaction. And those are not necessarily going to show up on a rating scale, but they're oftentimes very specific to an individual. And I think if there's a discussion about how does the individual's family, their spouse, their significant other, their loved ones, how do they notice if there's a change? And again, it's not the things that we're only going to pick up on rating scales. The other problem I think a lot for residual symptoms is especially unfortunately in primary care settings, where there's oftentimes so many other factors vying for attention. If someone's seeing their primary care physician, or if perhaps their gynecologist serves as their primary care physician, and they have 4 or 5 different medical problems they're reviewing, depression and bipolar illness oftentimes get shoved to the very bottom of the list, unless you can't find a cause for anything else, and then suddenly, mental factors, psychiatric factors suddenly move up on the list. But we found in STAR-D, for example, that there was actually more chronic depression in primary care settings than there were in psychiatric care settings, which really surprised us. It was exactly the opposite of what we anticipated to find. And we surmise that there may be multiple factors for that. One is there's a lot more comorbid medical conditions. Folks who are getting their medical care in primary care settings oftentimes have a lot more adversity, a lot more socioeconomic adversity that perhaps makes it harder for them to access psychiatric or specialty care. And also, again, it goes back to this kind of reprioritization. And there's only so much time in a primary care setting to go through all your high blood pressure, your cholesterol, the various aches and pains, and that depression oftentimes gets relegated to the very bottom, and I think that is one of the other things. The other factor I mentioned was inadequate assessment, and so often we forget to ask, even if we know what the symptoms are, we forget to ask, why are there remaining symptoms? I.e., why are there residual symptoms? And there are so many reasons for that, but that's what tends to be inadequately assessed. It may be related to inadequate treatment, perhaps simply inadequate dose escalation. Many people tend to think less is better, and this is the land of Mies van der Rohe here in Chicago, but less is not always more. And in fact, we found in STAR-D, interestingly, with antidepressant treatment, with a few exceptions, concerns and burden from side effects from antidepressants actually went down as the dosage went up. And we associated the increased dosage with better outcomes. And so I think sometimes just a reluctance or apprehension to optimize a treatment. And I'm not talking about always going to a maximal dose, but optimizing a treatment, whatever it might be. And that actually goes for optimization of psychotherapy. If you're seeing a CBT therapist once every 6 weeks, probably not going to get a lot of work done. So it's really in optimization of treatment. Other reasons for remaining or residual symptoms, other co-occurring illnesses, pain, residual pain, or thyroid problems, things that oftentimes are a little bit more covert, like sleep apnea, restless leg syndrome. All those things have been associated or are oftentimes co-occurring with mood disorders and may go under-recognized, yet contribute to residual symptoms. The use of substances, alcohol use, I mentioned earlier, but even the use of supplements, herbals, various botanicals, which are not always inert or benign. Other substance use, cigarette smoking, someone gets stabilized, and not just stabilized, but feels well, and then they perhaps start smoking a bit more, and actually the smoking itself induces the metabolism of their particular medication, so their effective dosage, the effective amount that they have available in their bloodstream actually drops. So things like cigarette smoking, poor sleep hygiene, which I appreciate your, Alan, you mentioning this idea of how important regularity in sleep-wake cycles is, and that oftentimes is a major factor. And then some things that are much less medically based, but nonetheless very individualized. Certain traits, I mean, some of us just tend to be a little bit more ruminative. But unfortunately, individuals, those of us who are a little bit more ruminative, might be a little bit increased risk also for recurrence of depression or residual symptoms. Because if you're ruminative, you have a hard time letting things go, have a hard time shutting your mind off from a particular worry, it actually becomes almost self-traumatizing. It disrupts sleep, it leads to more distress, and it can lead to greater symptomatology. And so there's a role for, again, a much more holistic role in terms of recognizing not just the medical factors, but recognizing a multitude of factors that can contribute to residual symptoms. Identification of other life adversities, socioeconomic adversities. We found in STAR-D that poor outcomes, probably not surprising, but it was important for us to identify this. Poorer outcomes were related to greater life adversity, especially social economic adversities. And I think that the lack of an appreciation, especially lack of appreciation by clinicians, of the role of rehabilitation, and I think this kind of maybe dovetails, Robert, with what you'll talk about in terms of the importance of recovery. Recovery and complete rehabilitation, and I use that word specifically because it's sort of analogous to someone who injures their hip. They're out skiing and they have an accident. They break their hip, and so they have hip surgery. That person's going to have to go through rehabilitation. They're not going to be able to go out and be fully functional, even after they get a new hip or after they get a new knee or whatever it may be. And so this idea that recovery is something that's oftentimes delayed long after the medical condition itself appears to be stabilized, and that's very true for depression, bipolar, and in fact, the longer someone has been in a depression, the longer it takes them truly to recover, because depression in and of itself is depressogenic. It reinforces certain behaviors, certain habits, things that just, in a way of living that, quite frankly, just sort of become ingrained. And so learning how to live healthy again is a real challenge for many people, especially when they've been depressed for a long time. And then last but not least, I'll leave with the last thing that I think is inadequate, and that's the amount of time that we oftentimes have to evaluate how someone's doing. And I think especially in some healthcare settings, that's a tremendous problem. And you have a chronic or recurrent depressive illness or bipolar disorder, it's absolutely impossible to truly do, I think, an adequate assessment in 5 or 10 minutes. But that's what, oftentimes, that's all clinicians are given, and oftentimes that's all that someone living with a mood disorder finds they can get. And I think that's a huge problem, and it's something I know DBSA has continued to advocate in terms of parity and adequacy, of true adequacy of care, not just good enough care. So I think I'll stop there.
Well, thank you very much, Bill. I'm going to disclose one of my wellness strategies. It's to celebrate my inner rock star, and I'm going to invite all of the panelists to join me, see if it works for you too, and we're going to talk into the microphone for our listeners out across the country. So, see if you like it. Give it a try. Works for me. And I think what you had to say, Bill, is so incredibly important. And I'd like to start with a really maybe simplistic question, but I think it's one that actually there is a lot of confusion about. When you say subsyndromal symptoms, or when you say residual symptoms, or if we say in a lay context, like leftover depression, or just a little depressed, what do we mean by that? And I wonder if you would kick off, Bill, with maybe a definition of subsyndromal and share that, but then maybe to the panelists who have experience of mood disorder, what does that mean to you? So might you channel your inner, I won't prescribe the rock star, Bill, but tell us about subsyndromal symptoms. Define that for us.
Well, just real quickly, subsyndromal symptoms refers to symptoms that don't quite meet the threshold for what a clinician would identify as meeting illness. And most of our psychiatric illnesses are diagnosed as syndromes. They're clusterings of certain symptoms, and we tend to look for X number of symptoms for a certain amount of time with a particular level of impairment. And subsyndromal things, actually subsyndromal symptoms are those that, they may not seem quite as bad. So they don't quite meet threshold for being fully symptomatic, for implying illness state as we currently conceptualize our disorders, our conditions, but rather they're subtle. They're simply subtle, oftentimes mild. I should add, though, subsyndromal and residual are not necessarily the same. You can have residual symptoms actually can be quite severe, but a person may just have one or two residual symptoms, but they can actually have significant impairment and intensity associated with those. Or a person may have lots of symptoms, but they're all real mild, and that would be subsyndromal.
Lowered treatment expectations impacted me on a very personal level for nearly a decade. I had one depressive episode in early adulthood, but I wasn't formally diagnosed with major depressive disorder until I was about 30 years old. When I began treatment, I knew very little about depression. My doctor and my therapist educated me on the clinical aspects of the disease, but I didn't have anyone to tell me how to manage its impact on my life. For one depressive episode, my doctor recommended a local partial hospitalization program where I learned the principles of cognitive behavioral therapy and how to apply them. This was a huge paradigm shift for me and really changed my life. Not only did I no longer feel like my depression was mostly my fault, but I figured out that I could actually manage it and minimize its impact on my life. After the support group that I was attending monthly was disbanded, I started looking online for other options, and I became acquainted with DBSA. I really liked the empowerment that their mission offers to those of us with mood disorders, as well as their emphasis on education. And with their help, I started a DBSA chapter in my local area, and we began hosting regular support groups. I learned there another component of wellness for me, and that's a sense of purpose. I wasn't working in my chosen field, and at the time that was causing me a lot of distress. But I discovered an important part of my identity in leading support groups, and that's that helping people manage symptoms and learn to lead productive and enjoyable lives again is something that's very important to me. I think I find in support group that there are a lot of things that aren't working right in getting people from surviving to thriving. I've had people come in and talk about their doctor and medical school professor tell them that, you know, meds can't do it all. You're going to have to do this on your own, with no explanation of what that might entail or how they might go from whatever relief their meds provided to feeling good again. We've had some doctors write their script without really asking how the patient's doing, are the meds working. There are some therapists who tell you, okay, well, that's great. Are you still working on that? And don't really challenge people. That isn't helpful either. But I think one of the most important things that we don't always recognize is that we really tend to limit ourselves to. With the struggle for self-esteem that we already face with depression or bipolar disorder, it doesn't always occur to us that wellness is not only possible, but that we deserve it. People are afraid to commit to new ventures, as Alan mentioned, because we're really afraid of disappointing other people, but we're also really afraid of disappointing ourselves. It's important to plan how to manage these issues and deal with them step by step if we want to make the transition from survival to thriving. As far as needs going forward, I think we need so much more education, both patients and professionals alike. We all have a lot of work to do. Peer support groups have made a huge difference in my life and make a big difference in the lives of most of the people I talk to who attend them. But we could still go further, and we still need to continue to work on how we see ourselves, how we manage our symptoms, and how we look to different therapies and strategies to help manage our disease and help transition from just doing better to feeling like ourselves again, enjoying every aspect of our lives as best we can.
Thank you so much, Rebecca. And what you just said hit me, feeling like yourself again. I think that's incredibly powerful. I remember thinking at one point, oh yeah, I used to be a person who really liked to go on a long walk. I said to myself as I found myself walking everywhere for a while. And that's something that was, to me, a sense of how I was returning to wellness. Would you talk a little bit, Rebecca, and I'd like to invite you, Robert, as well, to talk a bit about either how do you know that something is still wrong in terms of a symptom that still has impairment or something that's not how you want it to be, and how do you know that something's getting better, personally and individually? How do you see that there's something that is an aspect of wellness in your life? And you can start with either one. Rebecca, would you kick us off, and then we'll go to Robert?
Sure. For me, I know that I'm not doing well or that there's something that needs to be addressed when my dreams and my life don't match up very well. If there's a huge discrepancy between where I want to be in life and where I am, and I'm not actively working on taking steps toward that, then I know that there's something I need to look at for one reason or another. I've found that as far as realizing that something's getting better, my work with DBSA, when I realized that I wasn't just managing symptoms anymore, but I was actually feeling good, actually looking forward to doing things again, and looking forward to the support groups because I knew that we helped people, not just me. That made a big difference in my life, and it really changed how I saw myself, too.
Hi, I work in crisis, and in crisis, a lot of times we work directly with a client to work one-on-one for a 24 to 48 hour plan of attack, if you will, or plan of action that they can utilize for the next 24 to 48 hours to guide them, to be that beacon in the night, you know, if you will, and lead them toward better quality of life at that moment in time, whatever their crisis is that they come in for. When I see people come in, I see people who isolate, they alienate, they're self-deprecating, they might have low self-esteem. Family members, if they have family members left at that point, expectations often take the forms of, will you please take your psychiatric medication? Will you clean your room? Will you clean your car? Will you get out of the house once in a while? You know, and these all sound like very basic, regular things for everybody to grab hold of. But when you're in the grips of depression or bipolar illness, whether manic or depressed, you're going to wind up depressed at some point, probably, even if you do go manic, from my experience. But you know, these are very low expectations for anybody, I think, to make it through the next 24 to 48 hours. That's setting the bar really low. When I have the opportunity, I share the hope to dream big. About 14 years ago, I made a list of big dreams, and I carried it around in my wallet for a long time, and now it's like in my room in a safe place. And I used to look at it occasionally, and somebody told me to dream big, and I said, what do you mean dream big? And they said, in 10 years, everything you want to accomplish and more, I want you to put this down on this piece of paper. And here it is 14 years later, and I have a wife, and I have a family, and I have a job that I've been at for over 3 years, and I have, you know, I'm working on my CRSS, and I've accomplished college, and you know, to the point that I'm happy. And you know, I work with a great team of people, and I think wellness looks more in the face of that than in the face of disparaging condemnation or just depression. Just the idea of sometimes waking up and not wanting to die is really moving forward for some people. And that's been my case in a lot of times. But I really think that moving into wellness means doing what's in front of you, because that's the next thing that you have to do. You don't have to look at the whole big picture always, but you need dreams out there.
My goodness, that feels like we should drop the mic and just say peace out. I love to hear that, and I feel like that description of sometimes to wake up and not want to die. Can you imagine if that were the goal you wrote on a piece of paper? But it can be that's a big deal. And then the idea of something that seems impossible, that I see your wife right there. The things become reality. That's a really, really powerful description of the journey, and I thank you so much for that. And I also sense the momentum of the group, and as a person who works for a peer support group organization, the group always knows. And so I think it does make sense to go to Dr. Cook and hear a bit about research, and then to open it up to the great questions from the group, because these are better than anything I'm going to come up with, so I'm going to just go for it. So I'd like to hand the mic over to Judith Cook and hear about research and your experience with that. So I'll hand over this to you now.
Thank you, Alan. I'm going to ask my colleagues to my left if they will share their microphone stick, because I may be a researcher, but that doesn't mean I can hold a mic, read my notes, and talk at the same time. Okay. So, as you've heard, I'm a mental health services researcher. I study factors that lead people to recover and to thrive, hopefully, after they've experienced mental health difficulties. And sometimes these factors are service delivery programs or models like case management or a particular type of psychotherapy or supported employment. Other times they're characteristics of the individual that they were born with, like being a man or a woman, or their race or their ethnicity or how old they are. And other times they're factors that, that they live in, their life situation, like whether they have a safe neighborhood to walk in when they want to take a walk, and whether they live in substandard housing so that they have a decent kitchen so that they can cook a healthy meal, or have friends over to socialize. So all of those are factors that affect people's wellness and their recovery. But as a researcher, what's really important is the ways that we measure things as researchers. And which measures we use in our studies is also very important. And first of all, we have to be really careful to use outcome measures that matter to people in recovery. I've done a lot of studies where I've measured symptoms, or I've measured the number of times people go into the hospital, or I've measured how many hours of services they use, or how much those services cost. And those things are important, but I don't find that they necessarily matter to people who are searching for how to recover, looking for life circumstances or for service delivery models that will help them recover. So I think we need to be focused as researchers on asking people whether they feel they're at their maximal level of wellness, and also how they define wellness, which we really haven't done. We also need to measure their strengths and gauge their strengths and their positive feelings in relationship to their deficits and their negative feelings, because I believe that wellness is not just the absence of sickness. And so I think that's something we have to grapple with today. If we got rid of everybody's health and mental health symptoms, does that mean they would be well? No. And so I think that this notion of wellness is bigger than treatment. It's bigger than a mental illness or a physical illness, and has to do with the person's whole being as well as their life circumstances and their environment. Secondly, I think we have to be careful not to separate the mind from the body in our research. For example, we want to go beyond just measuring emotional states and make sure that we're also measuring people's physical health. And we need to find out whether both of those dimensions are well at levels that enable people to engage in valued social roles, which is another aspect of people's definition of wellness. Can they be an employee? Can they be a student? Can they be a parent or a friend to someone? That really is a major definition for many people of whether or not they feel well. So there are some ways that we can do this as researchers. One of them is called mixed methods research. And here what I'm referring to is the idea that we don't just count things and measure things with numbers. That's one way of measuring. But we also listen to people's words and their opinions and their experiences, their subjective feelings. And we use those words and experiences in order to measure whether people feel well and whether people feel that they're recovering. So mixed methods research is a very important tool that researchers can use. Another very important tool involves using peers as equal partners in our research. Peer research partners have to be involved in studies from the very beginning all the way through to the end. I mean, in the beginning, they will guide you to the important questions. They will say, that's a dumb outcome measure. Why are you measuring that? And sometimes as a researcher, I'll say, gee, I really don't know. I put that in to get funded, or, you know I can get an article out of it, but Yeah, I guess if I had whatever it was, I wouldn't really care about that outcome measure either. So peer researchers can guide you to the right questions, to the right ways to measure it. As you get further into your research, they can make sure that you're using strategies to gather data and conduct your research that are fair and that are ethical, because fair and ethical research generally produces more valuable findings and better data. And then when you're analyzing your data and trying to interpret things and, what you expected, the hypothesis you had was disconfirmed, many times peer researchers can, tell you why that might be, or can explain to you why your hypothesis was kind of dumb to begin with. And in the real world, things play out in a different way, where your hypothesis was based on the laboratory or what had been found in non-real world circumstances before. And then the last thing we can do as researchers, and there's many more, but I just wanted to measure those that I thought would be of the most interest to a DBSA audience, is we need to study people long enough to capture their recovery. Most research studies look at people for 6 months or a year. You're lucky if you can get funded to follow people for 24 months. That's just not enough time to recover and go on to live a life where you can measure whether people were able to work or get married or have children. We first discovered that people could recover from the research of folks that, like Courtney Harding or Martin Harrow, that studied people with particular diagnoses for decades, 30, 40 years. That's when we learned that recovery was possible. So we have to not be satisfied, given that our tax dollars fund research, we have to not be satisfied with studies that look at people over a 12-month period or a 24-month period and ask about how people do over the longer term. If we don't do the type of research that is what is really needed, then we don't obtain the knowledge that we need in order to ensure that services are effective and in order to ensure that people actually are recovering, given all the money that we're spending in trying to help them recover. And we have to have effective services, whether they're medications and therapy, and we have to have effective social supports, whether it's peer support through DBSA or the love of family members, in order to be truly well. But I want to return in the end to the fact that wellness is not just the absence of sickness, that the environments that people live in, and many of these environments are due to their mental illness, not to symptoms, but to the fact that they experienced downward social mobility while they were sick. They didn't get to finish their schooling so that they could get a decent job and have to do entry-level employment. These environments are what contribute in many ways to people's feelings of non-wellness. And this is what I think we have to work on in our advocacy, and why I think DBSA is such an important organization. We have to make sure that people aren't living in substandard housing, that they have financial security and aren't forced to live in poverty. And we have to not be okay with the idea that the best public housing is in unsafe neighborhoods. Those are really important factors, and all the treatment and therapy and even peer support in the world won't make up for environments that don't contribute to wellness.
Dr. Cook, thank you so much. And that actually leads perfectly to one of the questions that we had from out in our online audience. And you mentioned the idea of going to peers to help with definitions or with the measures that you start with in the first place. In terms of wellness, how do we measure that? I talked about it being self-defined, but are there ways that exist already or that we can think of now that actually look at measuring wellness as a contrast to illness? And I'll start with you, Dr. Cook.
So yes, there are a lot of measures of wellness, and what you might want to measure depends on what you really care about. There's measures of the extent to people that people feel that they've recovered. There's measures of their self-esteem. There's measures of how healthy they feel. There's measures of their level of participation in society. We have a lot of measures. I think the question is how they fit into the research question that we're asking, and how we can administer them and use them in ways that make sense given what we're trying to accomplish with our researchers, or with our research. But yes, there's plenty of measures out there.
And another great question, and this is the kind of question that I love, and I invariably see these questions from a DBSA audience. This one, several people asked in the room and online. How do I bring this up with my doctor? How do I bring up the idea of wellness or not being all the way there with my doctor? And whether a person who's, whatever side of the desk you have sat on, would someone get us started on thinking through how we can bring this up?
I'll use mine, thank you.
Yes.
I have actually brought it up with my doctor on a couple occasions. The first one actually didn't seem terribly interested in changing the way that he talked to me about symptoms, and so I moved on to a different one. I just said, I feel like we're not focusing on the right things. Yes, I'm sleeping a limited number of hours per night. I'm not staying in bed 12 hours a day anymore. But I don't feel good. I don't feel like I want to accomplish things the way I used to before the depression hit. And I see that as a problem. If your provider doesn't agree with you on what's important, then maybe it's a relationship that you need to reevaluate. There are so many doctors and therapists out there who really, truly, profoundly care about how their patients are doing, and you deserve one of those. And I would really encourage you to decide what it is that's most important to you and structure your wellness plan around that. You are the one in charge of the goals of your treatment plan. And it's hard to remember that sometimes, especially not when you're doing well. But when you start feeling better, keep reevaluating that plan. Make sure that the goals that you're working toward are things that matter to you now. Because what matters to you changes over time.
And I wonder, Bill, if you could comment on, as a clinician, you have, and we've mentioned this several times, only a small amount of time with your clients increasingly. So how do you make sure that you allow for the personally defined endpoints of treatment, and still hit the things that you need to clinically? To the extent we have clinicians listening, how can we begin to think about that?
Certainly. Well, first of all, I want to say I really respect your comments about the importance for the patient also to be very upfront and to ask, how are we going to know? What are we measuring? Are we measuring the right things? That is such an important conversation to have. And I think for clinicians, having the conversation at the first or second visit while the evaluation is still evolving is really important, because it's at that point also that hopefully you can sort of set a pattern for what sort of things you're going to be evaluating over time. There's sort of interesting phenomena that sometimes happens, I think, in terms of expectations that patients may have of their doctor. I've had many patients but I've had a handful of times where people have but have just chosen not to share very relevant information because they thought I wouldn't be interested. If they were if I was seeing them primarily for medical management, disease management of their illness, and they perhaps had a separate psychotherapist that they saw on a weekly basis, they would assume that maybe I might not be interested, that they're really struggling interpersonally, or that there's issues at work or what. And so I think it's really important for all clinicians regardless of the modality of the treatment, to let patients know they want to know about how a person is functioning in their entire life. And they need to have context. You cannot evaluate symptoms or the meaning of symptoms out of context, because what may be symptomatic for one person may be entirely normal or may be appropriate or may be transient, and you can't do that without an understanding of context. So there has to be a feeling of trust and belief that your clinician really does want to know what's going on in your life and needs to know in order to really make an appropriate evaluation of how things are going in partnership with you.
In terms of what we as people who have the lived experience go into, say, a doctor's visit with, again, on the idea of the limited time, how do you prepare so that you can bring up the idea of, am I getting better and still striving to wellness? How do you prepare for that visit? Rebecca or Robert, love to hear from either.
I was lucky enough to have treatment at a facility in Kansas at the time that was outstanding in the country and provided long-term treatment, which very few places offer now. And this was in 2002, but I was encouraged by my doctors to use the medical library at the facility. It was a teaching facility as well. And I was kind of honored to go into that library to begin with. I thought, wow, these huge minds come in here and grow and figure out all these cool things about us and try and help us. And so suddenly I started being able to speak the speak a little bit. And I could understand maybe where my doctors or where my clinicians were coming from. And that was a huge benefit. I think the more we educate ourselves on our condition and on the quality of life that we want and on the modality of treatment that we need, this is a patient-centered treatment modality that when it comes from a patient or a client or a guest or whatever you call your people that you work with, when it comes from there, it comes from the source. And I think most people best know what they need. I mean, we need help along the way, and we need help with modality as far as implementation of some of those ideas and really getting better and tracking some of those things and those tools that you learn in medical school and in your advanced degrees. But I think every day when I go into work, the number one thing that I put on a chart, if I have to chart, is active listening. It's always the first thing that I put, because if I don't actively listen to my client, I'm not going to receive their information correctly.
Dr. Gilmer, yeah.
Alan, may I just recall there was actually one other thing that maybe is a more direct response to your question about the amount of time, which I don't think I really addressed adequately. I think that's where measurement-based care can be extremely useful for clinicians. And measurement-based care, certain types of instruments that review a list of symptoms, how severe, how frequent. For many of my patients, I send them home. I'll email them a PDF of a standard one that they can fill out and bring in with them. So I don't have to go through all the things with them each time, but when they come in, we can look at it together, and the discussion starts right from that moment. Or the wellness tracker, for example, or things like that. DBSA has a wellness tracker that you can track your symptoms on a daily basis and how well you're doing, how much sleep you're getting, things of that nature. Sleep logs. It's incredibly useful. Sometimes my patients will send them to me in advance so I can take a look at them, so I'm prepared when they come in. So we have a much more efficient visit. We can cover a lot of ground because I'm not spending all the time in the visit just having to go through the list. Some of that work's done ahead of time. And I think if a patient, if a person living with depression getting treatment can figure out a routine with their clinician to monitor their symptoms that really facilitates best knowing what's going on and to make it the most efficient and most effective. And by efficient, I don't mean the reduced amount of time, but so you can cover the most information and be the most thorough in whatever amount of time you have.
I think that that's a great, I appreciate your bringing up the wellness tracker, and the idea that is sort of coming through, I think, in a lot of these points is the idea of preparation and the idea of a platform for your listening and sharing. The idea, if you've got a common framework, if you agree upon what you'll measure together, then you know what you're working from, it's consistent. I think that's really powerful. And I'd like to pose a question, a closing question. We have covered a number of the questions from the group through the dialogue. We also have some that are really marvelous and we're not going to have time today. And so whether it's these panelists or folks that I will find them, we will answer these questions. So we will find a way to perhaps post them. I don't know how we're going to do it, but we're going to answer your questions, folks, because they're awesome. And our webmaster is right behind the camera as I'm looking at you, and she's thinking, I'm the one who has to figure that out. So, so we're making a big job for our webmaster. No, I really appreciate the questions and want to honor them and ask something that, you know, can we target both fewer symptoms and more wellness? This was something that actually our moderator today was to be Rakesh Jain, who was not able to be with us, and we send our good wishes and positive energy to him. But he asked this question and showed this chart, and it kind of rocked my world. The idea that, well, gee, I could look at both. And the idea that, yes, we can be on a continuum of symptoms. We can have none, we can have a lot, and everything in between. But the idea that there could be wellness also. And in this quadrant, you see the idea of somebody who may have a lot of symptoms, but also a lot of the positive aspects of wellness, the resiliency, the systems and structures, relationships, various ways of keeping yourself you know, well to offset those symptoms. Dr. Jain used an example that's very powerful, the idea that from the historical record, from what we can see, Abraham Lincoln was depressed most of the time. Really, really struggled every day, but had a lot of wellness and a lot of structures to keep it. Help with getting to sleep, which was hard for him. He had a whole team helping him to get to sleep. It's easier, I guess, if you're the president, but still, it's something that, that he monitored closely, forcing himself to interact with people. And again, that human contact is a marker of wellness. I love that idea, and we've added to the DBSA Wellness Tracker the World Health Organization 5-point Well-Being Index. We realized that our wellness tracker was tracking illness almost entirely, and so we added a wellness measure. This is the beginning of a shift and a change, and I want to thank all of our panelists, William Gilmer, Rebecca Folk, Robert Haggard, and Judith Cook, for entering into this dialogue, the folks here in Chicago at the Chicago School of Professional Psychology, and all of you online in Overland Park, in Chicago, at that viewing party, in Louisville, in Wellsville, New York. We thank you for being with us. So we'll have a video of this event for folks that you might want to recommend it to at dbsalliance.org/BINW, Better Is Not Well. We'd also very much appreciate it if you'd fill out our post-event evaluation survey. You can find that at BINW eval after our web address. And now I'd like to say a thank you to a team that's really worked for about 15 months in getting this to be a reality. I'd like to start by thanking Holly Cates and especially J.R. Richards, who listened to our idea about thriving being absent from the conversation and really seized upon it. And I thank them for their belief, as well as the DBSA board and staff team, the wonderful staff that's here and made this event possible. Thank you so much. And I'd like to thank the panelists once again. I'd like to thank our viewing party hosts, Eli Lilly and Company, which made the event possible and allowed us to be able to stream it to all of you watching around the country. And I hope that this is just the beginning. I thank all of you for being interested in the idea of striving to go past better and all the way to well. And once again, I hope that you'll fill out our online evaluation form. And be sure to sign up for our notices of monthly events at dbsalliance.org/join. Thank you again, everyone, for being with us, and let's keep working to go from better to truly well. I'm Alan Doderline with DBSA. Thanks so much.